I'm one of the infectious disease doctors here. And today we're going to talk about one of the things people think about when they think bread and butter medicine, and that's community-acquired pneumonia. So the learning objectives for today, we're going to define severe community-acquired pneumonia and triage which patients with pneumonia need admission to the hospital, and then where the best site of care is. When to consider MRSA and Pseudomonas as etiologies of community-acquired pneumonia. List diagnostic studies indicated for CAP, and then select empiric therapy for CAP. What we're not going to cover, hospital-acquired pneumonia, ventilator-associated pneumonia, and COVID-19. There's just too much to try to pack into 1 hour to cover these topics. So the Infectious Disease Society of America and the American Thoracic Society published joint guidelines for the treatment and diagnosis of community-acquired pneumonia. And these were updated in October of 2019. So those of you who heard this talk last year, it is significantly different than what we talked about last year. The guidelines focus on adults who don't have any immunocompromise, no HIV, no transplant, no travel history. One of the ways that they have changed a lot is the recommendations are different for severe versus non-severe pneumonia. So we'll spend quite a bit of time trying to classify patients into whether they have severe or non-severe. In the past, sets of guidelines determined the guidelines for treatment based on the site of care, whether the patient was in the ICU or a floor patient, but now it's classified by the severity criteria rather than where the patient is physically located. Now it's not going. Okay. All right, now it's moving again. Okay. So we're going to start out with a case. This is KS. She's a 78-year-old woman with COPD, not on home oxygen, and hypertension, who was admitted in March for unbearable right upper quadrant pain, 8 out of 10, radiating to the back. The pain is worse with coughing, and it seems to be that her cough is at her baseline. She's had no change in sputum quality or quantity from baseline. She's a smoker and lives with her grandsons. Her father had TB. Temperature is 36.9, heart rate 80 or 96, and she's sitting 94% on room air. She's alert and oriented. Her lung exam shows decreased breath sounds on the right versus the left, and there's egophony at the right base. Her abdominal exam shows some right upper quadrant tenderness and tenderness in the right flank, but no rebound or guarding. Labs are notable for white blood cell count of 15.2, hemoglobin 12, platelets 179. Creatinine is 1.25. Her hepatic panel is normal, and you can see her ABG there. This is her chest x-ray. Things to note on here, she should have a nice crisp heart border, and you're seeing some haziness over there, and that's suggestive of an infiltrate on the right side. She had a CT scan, which confirmed an infiltrate on the right side here. So based on her infiltrate and symptoms, she's diagnosed with pneumonia. I should mention that the guidelines from the IDSA and ATS specifically focus on people who have confirmed pneumonia. They don't talk very much about how to get to that diagnosis. So everything that we're talking about in the guidelines assumes that the diagnosis of pneumonia has been established, and that symptoms plus an infiltrate on chest x-ray. So there's several scores to measure severity of illness in pneumonia. Two of them are the Pneumonia Severity Index and the CRUMP 65. And these models are prognostic for mortality, and they can be used to identify patients who should be admitted to the hospital for their pneumonia. These scores don't inform the level of care, whether the patient should be in the ICU or the floor, and you should always use additional information and your clinical judgment rather than just the score to decide who needs to come into the hospital, including whether the patient can take oral medication and if they have good outpatient support. So this is the Pneumonia Severity Index. It's based on a number of different factors, including demographics, comorbidities, physical exam findings, and lab and radiograph findings. As you can see, a downside of it is that it's pretty cumbersome. There's a lot of different things to remember, and they have different point values. The good news is that if you have a medical calculator app on your phone, the PSI is included in most of that. The one that I use is MD Calc. If you don't have it or a medical calculator, I would encourage you to get one. And if you have it on your phone already, get your phones out because we're going to do some practice in a minute or two. So this scale is used to calculate a score, and it stratifies patients into 5 risk groups based on their point total, and this correlates with the risk of mortality from pneumonia. And as you can see, the higher the score, the higher the mortality, both in all adults with CAP and nursing home patients with CAP as well. Patients who fall into the lowest risk groups, 1, 2, and 3, can probably be treated as an outpatient, especially if they're in group 1 or 2. If patients fall into group 4 or 5, these are higher risk patients for mortality, and hospitalization is recommended. So this is a summary of the case that we started talking about, and I want you to take a minute to either use the table or your app to calculate her PSI score. I'll give you 30 seconds or so to work on that. All right. So she gets 68 points for her age minus 10, and 30 points for having a pH on her blood gas that's less than 7.35, which puts her PSI score at 98. And then looking at the table of risk, she's in category 4, and hospitalization is recommended for her. So the CRUMP 65 is another prognostic scale. It's only based on 5 different criteria, and that's where the mnemonic comes from. C is for confusion, U, uremia, R, respiratory rate, B, blood pressure, and the 65 for age over 65. So it's easier to remember and based on fewer markers. The downside of it is that it kind of overclassifies the severity of illness and puts more people in the hospital than the PSI. It also is less discriminative when it comes to predicting mortality. Patients with a score of 0 or 1 are at low risk for mortality, and outpatient care is recommended. If they have 2 points, that's intermediate, and they can be considered for observation admission or an inpatient admission. And then greater than 3, then inpatient is recommended. So the guidelines prefer the PSI because it's more discriminatory, and that's the one that we'll focus on for the rest of the talk. But if we look at our patient, using the CRUMP 65, she gets 2 points, and so that would indicate the need for probable hospital admission. So as I mentioned, these scores can tell you where the patient should be treated, hospital versus outpatient, but it doesn't give a hint as to where you should put the patient, whether they're okay for the floor or if they should be admitted to the ICU. And the severity of illness will also become important when we're talking about diagnostic testing for CAP and empiric treatment for CAP. So these are very important criteria to know. So the guidelines have 2 major criteria for severe pneumonia and 8 minor criteria. The major criteria are pretty obvious. If they're on a ventilator or they're in septic shock, it's severe pneumonia. That's pretty straightforward. So if they have either of those, then it's severe pneumonia. The minor criteria are listed here, and you need 3 for severe community-acquired pneumonia. And a downside is that these are difficult to remember and it's quite a long list. And unfortunately, I could not find this scale in any of the medical calculators. So hopefully this little mnemonic will help you in remembering what the criteria for severity of pneumonia are. So if patients have 3, they may CRUMP. So CRUMP with 3, C for confusion, R for respiratory rate, U for uremia, M multilobar, P is a PaO2 to FiO2 ratio less than 250, white blood cell count less than 4,000, IV fluids needed for hypotension, thrombocytopenia less than 100, or hypothermia less than 36. So we'll be using these criteria and a few other practice cases to determine whether the pneumonia is severe or non-severe. And looking at the case that we already talked about, she has one of the minor criteria, and so she would be considered non-severe community-acquired pneumonia. So let's do case number 2. This is a 65-year-old woman with CHF, coronary artery disease, diabetes, end-stage renal disease on dialysis, sleep apnea, and remote breast cancer. She presents in late December with 1 week of cough productive of white sputum, no fevers, no shortness of breath or chest pain. She has had some myalgias, no sick contacts. She goes to dialysis 3 times per week and hasn't missed any sessions. Her last hospital stay was 4 months ago for decompensated heart failure. Her temperature is 38.2, heart rate 108. She's satting 100% on 2 liters. On lung exam, she has diffuse bronchi. White blood cell count is 5.8, platelets 77, BUN 16, and creatinine 5.5. Remember, she's on dialysis. And her ABG has a pH of 7.29, a PCO2 of 49, and a PO2 of 136. This is her chest x-ray. And this is how the heart border should have looked in the first x-ray we looked at, nice and crisp. So she's okay there, but you lose the diaphragmatic border over here and the heart border on the left, so that's suggestive of an infiltrate there. So let's take a minute to calculate her PSI. All right, so she gets 58 points for her age. Oh, my math is bad. It should be 55 points. 10 points for her history of heart failure. I didn't give her the points for neoplasm because it was remote and she wasn't on any treatment for it at the time. Renal failure, she gets 10 points. And then her pH is less than 7.35, so she gets points for that, for a total of 108. Looking at the scale, that places her in the risk category 4. So where should we treat her? Inpatient, yep. And then these are the criteria, minor criteria for severity. And I helped you out. She only has 1, thrombocytopenia. So how would you classify her pneumonia? Does she have non-severe community-acquired pneumonia, severe community-acquired pneumonia, healthcare-associated pneumonia, hospital-acquired pneumonia, or ventilator-associated pneumonia? Okay, yes, non-severe community-acquired pneumonia. So even though she was in the hospital 4 months ago, that isn't recent enough to be considered in our decision-making at this point. And she did not meet the criteria for severe. Obviously, she doesn't have ventilator-associated pneumonia. So the classification of pneumonia requires a little bit of a historical perspective to understand some things and to clarify some thinking that that may still be lingering out there. So previously, we defined CAP as pneumonia acquired outside of the hospital setting. That has not changed. And hospital-acquired pneumonia as pneumonia not incubating at the time of hospital admission and occurring greater than 48 hours after admission. And that definition hasn't changed. And then ventilator-associated as pneumonia associated with a ventilator, obviously. So in probably about 15 years ago, they came up with this designation of healthcare-associated pneumonia because we realized that people who had had a recent hospitalization in the last 90 days or who were residents of a nursing facility were at higher risk of having drug-resistant pathogens like MRSA or Pseudomonas. And so the guidelines developed this category of healthcare-associated pneumonia, or HCAP, to define people who needed to be covered for those pathogens. Unfortunately, as time went on, we realized that this wasn't as common as was initially thought, and we were way overusing drugs to cover MRSA and Pseudomonas, which was breeding resistance and other collateral side effects. So in 2016, we got rid of HCAP, and that's not a thing anymore. The other reason that it was gotten rid of is people were extrapolating that to not only inpatient hospitalization in the past, but also if the patient was on dialysis or had frequent exposure to the healthcare system. So now it's a much more restricted definition for hospital-acquired pneumonia, and that's pneumonia not incubating at admission or occurring 48 hours or more after admission. And instead of just offering broad coverage for any of these categories, we now look at the risk for Pseudomonas or MRSA in that individual patient and then decide if they need to have those bacteria added, or those antibiotics added. So CAP is any pneumonia acquired outside of the hospital setting, and that's what we'll focus on for the rest of the talk. So you might say, well, who's at risk for MRSA and Pseudomonas? When do I need to think about these things? So there are three criteria in the most recent guidelines: having a positive respiratory culture for MRSA or Pseudomonas in the past year, or hospitalization and receipt of IV antibiotics in the last 90 days. Just being in the hospital, like that lady was for her heart failure exacerbation, is not enough. You have to also have received IV antibiotics. There's this third category in the guidelines called locally validated criteria that are pretty vague. At Metro, some of our local criteria for a risk for Pseudomonas are having severe bronchiectasis, severe COPD with an FEV1 less than 30, or having a tracheostomy. We don't have any locally validated criteria for MRSA. So if you remember the first two criteria, those are going to be the most important: prior respiratory culture in the past year for one of those pathogens, or hospitalization with receipt of IV antibiotics in the last 90 days. So whether or not we test for different pathogens depends on how severe the pneumonia is and where they're being treated. For outpatients, if they have an uncomplicated pneumonia, it's not always needed. The main reason that we test in the inpatient setting is if the results of that test are going to change our treatment in one way or another, either addition of therapy for a pathogen that we might find, or taking away therapy that we've already started. It also can look for unusual pathogens. So if you have a reason to suspect something weird, then getting cultures is good up front. And as we're finding out, it may be important for public health reasons too. If you're all of a sudden seeing a bunch of weird pneumonias in people you don't expect to see pneumonia in, then it might be a new or emerging disease. So the indications for testing are based on whether you determine the patient to have severe pneumonia or non-severe pneumonia. In the outpatient setting, the only testing that's recommended is an influenza test. Again, that's because this is going to change your management. If they test positive for influenza, then we'll give antivirals. In the inpatient setting, if someone has severe pneumonia, then we're going to look for resistant pathogens with blood cultures and sputum cultures. There's also urine antigen tests for Legionella and pneumococcus that are recommended for severe inpatient pneumonia. And again, your influenza testing. The place where it's a little different is in non-severe inpatient pneumonia. You may consider doing cultures if the patient is going to be treated for MRSA or Pseudomonas, or if you're considering treatment, or you would add the treatment if it were positive. So if you're starting therapy for MRSA or Pseudomonas, you should get cultures. Or if they're at risk, you should get cultures. So it's blood cultures, sputum cultures, and then we also recommend here at Metro getting a nasal screen for MRSA. The positive predictive value for a positive screen is not high, but the negative predictive value of a negative screen is good, meaning if the MRSA nasal screen is negative, then we would feel comfortable not treating MRSA pneumonia. The upside of the nasal screen is that it comes back a lot faster than the culture, and you'll usually have results within 24 hours and can modify your therapy based on that. You'll notice that procalcitonin, there's a no for all of these. Even though procalcitonin has been shown in studies to correlate with the bacterial etiology, there's no cutoff that's predictive enough in a single patient for us to use this to determine whether or not to cover with antibacterials. So that's not recommended as part of the guidelines in working up a patient with an infiltrate. One other caveat, ordering a sputum culture doesn't necessarily mean that a sputum culture will be done. A lot of times it's ordered in the emergency room and it may say collected in EPIC, but either the cup sits by the patient's bedside, sometimes full of sputum even, and it never makes it to the lab. It's hard to go back in time and collect that later on. And so it's worth due diligence to ensure that that specimen actually makes it to the lab, so that 2 days from now you're not trying to decide what to do with cultures that were sent 2 days into therapy. And again, when do we worry about MRSA or Pseudomonas? If they have a prior culture, if they've been hospitalized and given IV antibiotics in the last 90 days. So the conclusion of the case that we were doing, she was admitted to the regular medical floor. She did have blood cultures and sputum cultures done, even though she didn't have any risk factors. This was before we had these guidelines. And she did have an influenza test done, and it came back positive for influenza A. All right, so the next case is a 56-year-old woman with COPD. She's on home oxygen at baseline, colon cancer that was resected 6 years ago and without sequelae. She's admitted with 1 week of worsened headaches, dyspnea, and body aches. She also had a cough productive of yellow sputum. She was hospitalized 30 days ago for a COPD exacerbation and was treated with PO, azithromycin, and prednisone with improvement. 8 months ago, she grew MRSA from her sputum. Her exam is notable for bilateral expiratory wheezing and a high white blood cell count, 23.5, 16% bands, 70% neutrophils, and her ABG is listed there. I forgot to put the vitals on this slide, but they're here for you. So why don't we calculate her PSI. All right, so she gets 46 points for her age. She has a pulse rate of greater than 125, 30 points for her pH, and 86 points total. So that puts her in category 3, which per the guidelines you can consider someone for outpatient therapy. So she sounds pretty sick. I'm not sure I would feel comfortable treating her in the outpatient setting. And this is an example of how the PSI can be a guide, but you should also use your clinical judgment when deciding where to treat someone. Things you might consider admitting someone with a low PSI or a curve 65 if they have a complication of the pneumonia itself. If you're worried about an exacerbation of an underlying disease, like in her case, the COPD. If the patient can't take oral medications reliably or receive outpatient care, maybe they are housebound in a wheelchair or they have a PEG tube and you're worried about absorption. If they have multiple risk factors that are on the borderline of qualifying for inpatient care, or if there's other medical or psychosocial needs that might require hospitalization. They're having vomiting, injection drug use, homelessness, or cognitive dysfunction. So the PSI is a guide, it's not the end-all be-all. And then looking at her severity criteria, she meets 2 of these, a PaO2 to FiO2 ratio less than 250, and her platelets are also low. So when you only have the liters of oxygen that they're on and you need the FiO2, a good rule of thumb, room air is 21% oxygen and then adding 4% for each extra liter they're on. So she would be on 28% roughly because she's on 2 liters. And then you can use her PaO2 to FiO2 using 0.28. And then her ratio is less than 250 when you do that. Is she at risk for MRSA or Pseudomonas? Remember the risk factors are previous MRSA or Pseudomonas culture. She had one 8 months ago, or hospitalized and given IV antibiotics in the last 90 days. So even though she was hospitalized 30 days ago, she only got oral antibiotics, so she would not meet that criteria, but she has had a positive culture. So we have someone with non-severe community-acquired pneumonia, we've determined that, and she's at risk for MRSA. So what regimen would you like to start empirically on her? I purposely left vancomycin off of there. So is she at risk for Pseudomonas? She hasn't had a positive culture for Pseudomonas. She hasn't been hospitalized with IV antibiotics, so I wouldn't be worried about that, but we've already established she has an MRSA risk factor. So I would do D, treat her for community-acquired pathogens plus an add-on for MRSA. Vancomycin you would use if you were worried about Pseudomonas as well. Cefepime is an add-on drug for Pseudomonas. And the other ones are both choices for when you're not suspecting those pathogens. And I'll show you a table of the regimens for different levels of pneumonia here. So if someone has outpatient community-acquired pneumonia, they're healthy, they have no comorbidities, there's no risk factors for MRSA or Pseudomonas. The 2 recommended choices are amoxicillin and doxycycline. In prior guidelines, azithromycin or clarithromycin were suggested as monotherapy, and that was the go-to drug for outpatient pneumonia. However, pneumococcal resistance to the macrolides has grown in the last few decades, and so azithromycin is no longer recommended for monotherapy, except in areas where the resistance rate is less than 25%, which is virtually nowhere in the U.S. Our resistance was 33% at Metro in 2019. So the big change in the guidelines here, no macrolide for monotherapy. Either go with high-dose amoxicillin or doxycycline for outpatient community-acquired pneumonia. If the patient has comorbidities, which includes a large range of different things. Then we use either a respiratory fluoroquinolone as monotherapy, that would be levofloxacin or moxifloxacin, or a combination therapy, amoxiclavulanate, cefuroxime, cefpodoxime, plus a macrolide. This gives atypical coverage as well as coverage for strep pneumo, including macrolide-resistant strep pneumo. The respiratory fluoroquinolones cover both atypicals and typical pathogens for pneumonia. So if you have an inpatient that has community-acquired pneumonia without risk for MRSA or Pseudomonas and it's non-severe, there are several possible combinations that you can give. The one in blue here, ceftriaxone and azithromycin, is the regimen that's recommended at Metro. And so I've highlighted it there. The other options would be to use amp-sulbactam, cefotaxime, or ceftaroline with either a macrolide or doxycycline, or monotherapy with a respiratory fluoroquinolone. And what are the risk factors for MRSA and Pseudomonas? Previous culture in the last year, or hospitalized and given IV antibiotics in the last 90 days. I hope you're seeing that this is an important point that I'm trying to make. So in patients that have severe pneumonia, no risk for MRSA or Pseudomonas, the regimen is actually the same, ceftriaxone plus azithromycin. And we would not use levofloxacin or moxifloxacin by itself in severe inpatient pneumonia. So for patients who do have risk for MRSA or Pseudomonas, it depends on if they have non-severe or severe pneumonia. And the difference is if they have prior isolation of that pathogen, you'll add coverage and then de-escalate if the cultures are negative. If they only have a risk factor for having a resistant pathogen, like they've been in the hospital but they've never had it isolated, then you'll get the cultures in non-severe pneumonia but only escalate if you isolate something. We always want to try to use the narrowest antibiotics possible in the beginning while minimizing the risk that we're not going to cover something that could be there. So for non-severe pneumonia and they have a prior culture, add the coverage, then de-escalate. If they only have a prior hospitalization, you'll get the cultures and escalate. For severe pneumonia, across the board, you'll add the coverage and de-escalate if the culture is negative. So what drugs do we add on for patients who are at risk? For MRSA, the major add-on is vancomycin. You can also use linezolid as an add-on in pneumonia. That has MRSA coverage. If you're suspecting bacteremia, this is not a good choice because of its bacteriostatic ability. But if it's just in the lungs, then you can use linezolid as an add-on. Add-on drugs, if you're trying to cover Pseudomonas, are cefepime, ceftazidime, piptazo, meropenem, or aztreonam. The recommended add-on drug here at Metro in part depends on if they have a past isolate, what it's susceptible to. And if it's pretty susceptible, we prefer using cefepime or ceftazidime over piptazo or over meropenem. Especially when you're using vancomycin. If you use vancomycin and piptazo together, the risk of renal dysfunction is much higher than either drug by itself. If you pair vancomycin with cefepime or ceftazidime, however, that risk of nephrotoxicity is a lot lower. If it's just for addition of Pseudomonas coverage, going with cefepime or ceftaz is better. Meropenem also has a lower nephrotoxicity risk, but it's also can induce resistance in other gram-negatives. And so for antimicrobial stewardship purposes, we try not to use meropenem except as a last resort. And then aztreonam would be a drug to consider in someone who has a penicillin allergy. Let me see how we're doing on time. I think we're doing good. So one other change that happened in the guidelines is in the past there was a section that allowed for modification of coverage if you are suspecting aspiration in a patient. But newer data suggests that most patients who aspirate gastric contents have aspiration pneumonitis, which is a chemical reaction and not really an anaerobic infection like we previously thought. And this gets better without antibiotics. So several recent studies of acute aspiration in patients in the hospital have showed that anaerobic bacteria really don't play a major role in the etiology of aspiration. And so adding coverage is not recommended for suspected aspiration pneumonia unless they have a lung abscess or empyema that you see on imaging. So even in patients who were drunk and passed out and you think they could have aspirated, still ceftriaxone and azithromycin plus MRSA Pseudomonas coverage if they have a risk. All right, so case number 5. This is a 56-year-old woman admitted for worsening cough and production of yellow sputum worse than her baseline. She's short of breath and has new oxygen needs. Her past medical history is significant for stage 4 non-small cell lung cancer, and she received carboplatin and pemetrexed last month. That course was complicated by neutropenic fever, for which she was hospitalized and received IV antibiotics. And she's allergic to penicillin, which caused hives 40 years ago. On exam, her temperature is 36.6, heart rate 82. She's satting 97% on 5 liters. Has decreased breath sounds on the right, and the rest of her labs are there. You'll note that her platelets and her hemoglobin are low, probably from chemo, but her creatinine is relatively normal. This is her chest x-ray. This was 2 months prior to admission, and then here is this admission. Things to note here, obviously the little green crosses are a hint that the radiologist saw some nodules, probably consistent with her lung cancer. But she has infiltrates on both sides, which makes it multilobar. I hope you remember that from one of the lists that I've showed you. So let's do her PSI score. All right, so she gets 46 points for her age. She's getting active chemo for her neoplasm, so she gets 30 points for that. 30 points for her pH. Oh, her pH actually wasn't less than that. I thought I changed that to make her qualify. 10 points for her hematocrit, which gives her 116 or 86, depending on how you calculated it. So that would put her in 4 using a lower pH, sorry. And I think even if her PSI was 86, I would probably put her in the hospital because of her comorbidities and risk for neutropenia. So here's her severity criteria, and this we saw multilobar, so she gets a point for that. Her PaO2 to FiO2 ratio, when you calculate it, is less than 250. And remember, if they're on oxygen, 0.21 plus 4% for each liter after that, so 5 liters would be roughly 0.41. And then she has low platelets, less than 100. So she has severe pneumonia. How about, is she at risk for MRSA or Pseudomonas? Yeah, she was hospitalized last month for neutropenic fever and got IV antibiotics. So no prior culture, but she was hospitalized and given IV antibiotics in the last 90 days. So we've established she has severe CAP. She does have risk for MRSA or Pseudomonas, but she hasn't had any positive cultures. However, she has a penicillin allergy. So we aren't going to talk a lot about determining whether the penicillin allergy is real. Let me see. Let me do this slide first. So she reported an allergy of hives 40 years ago. So we can classify penicillin allergy into mild, which are allergies that don't have features of an IgE-mediated reaction. That might be a rash if they just had isolated mild hives. We become a little more concerned if patients have an IgE-mediated reaction with anaphylaxis, angioedema, wheezing, hypotension, hives everywhere, skin desquamation, or any organ involvement. So that's a more serious reaction. And then very serious delayed reactions, type 2, 3, or 4 would be things like Stevens-Johnson syndrome, TEN, if they got a drug-induced hepatitis, DRESS, rash, eosinophilia, and systemic symptoms, serum sickness, or acute interstitial nephritis from the drug. That would be considered a serious reaction. So in her, we've determined that she has severe pneumonia, and she does have risk factors for MRSA and Pseudomonas. Because she's severe, we want to give her this coverage and then de-escalate if negative. If she had not qualified for severe pneumonia, then we would get the cultures and escalate only if those cultures were positive. So in people who have a mild allergy, it's reasonable to use cephalosporins or carbapenems. The cross-reactivity is very low for this type of reaction, and it isn't life-threatening if it happens. If it's an IgE-mediated reaction, then we try to avoid cephalosporins, but it's reasonable to use a carbapenem such as meropenem in this type of reaction. If there's a serious delayed reaction, then we avoid all beta-lactams and monolactams, so no penicillin, no cephalosporin, no carbapenems. And so these are the recommended regimens in someone who has a severe or who has a penicillin allergy, and it's based on whether you classify their allergy as mild, IgE-mediated, or serious. And you don't have to remember all of these. There is a pneumonia order set in EPIC. It's currently being updated with the most recent guidelines, but if you use that order set, it will guide you through all of this, including the definitions of penicillin allergy and when to cover for Pseudomonas and MRSA. So if they only have a mild penicillin allergy, then the recommendations really don't change. It's still ceftriaxone and azithro for straightforward non-severe or straightforward severe CAP. If they have a positive Pseudomonas culture that you want to cover for non-severe, then the ceftriaxone is changed to cefepime. And if they have severe and have a positive Pseudomonas risk, even if they don't have a positive culture, then you would also cover for Pseudomonas. And then you can see the other recommendations here for people with allergy. And the difference is that whether or not it's empirically covered or whether you wait for cultures. And for non-severe, unless there's a history of a positive culture, then we wait for the results. So to summarize, the key changes in the 2019 guidelines is that severity is classified by criteria rather than the site of care. Azithromycin monotherapy is no longer recommended for outpatient or inpatient pneumonia. And coverage for MRSA and Pseudomonas should be given for those at risk. There are tools available to use in conjunction with your clinical judgment to determine the most appropriate site of care. We talked about the PSI being one of them. For non-severe CAP, then diagnostic studies may not be needed, but if you're considering adding Pseudomonas coverage or MRSA coverage, then you should collect the cultures and then escalate or de-escalate as appropriate. And as I mentioned, the empiric treatment recommendations and definitions are in the pneumonia order set in EPIC. To go back to our learning objectives, we defined severe community-acquired pneumonia and triaged which patients require admission using the PSI, and determined the severity of pneumonia and whether to admit to the ICU based on the severity criteria, the CRUMP with 3. We talked about when to consider MRSA and Pseudomonas as etiologies of CAP. And the diagnostic studies that are indicated for CAP would be sputum cultures and gram stain, the MRSA nasal screen, blood cultures, Legionella antigen, strep pneumo antigen, and the flu swab. For non-severe pneumonia, if you're not covering for MRSA or Pseudomonas, the only thing that's indicated is influenza swab. For severe pneumonia, or if you're worried about MRSA or Pseudomonas, then also blood cultures, sputum, and MRSA screen. And then the empiric therapy for CAP is ceftriaxone and azithromycin, plus or minus add-on coverage for MRSA or Pseudomonas if indicated. And when do you worry about it? One more time. Previous MRSA or Pseudomonas culture in the last year and hospitalized and given IV antibiotics in the last 90 days. And I think that is it. I can take any questions.